Well, there are lots of different causes of back pain that often seem very insignificant. For example, posture being one of them. Patients who have sit all day, or patients who dig ditches all day, or patients who sit on a bus all day and drive a bus. These are some of the causes are postural, so people who do certain types of activities and jobs. For the most part, we really don't know what the causes the vast majority of back pain. And back pain in 90% of cases, we don't know what the major cause of it is. Is it muscle? Is it joint? Is it nerves? We really don't know. In about 10% of cases, we can actually identify the actual cause of the pain. So that's what makes sometimes back pain a little bit difficult to treat. In the obvious ones, patients fracture their back, they have a fall. Patients who have spinal stenosis because of degenerative causes in their back, or patients who have herniated discs. These are what we call specific causes of back pain. But again, for the vast majority, we don't know what the main cause of back pain is. And that's why it's so frustrating to treat, and that's why we don't seem to have very good success generally in treating back pain. My theory is that I think it has to do with the evolution of the spine. We started off as quadrupeds during evolution, and now we're upright, walking on 2 feet. And my theory is, and I think there's a lot of people who think that this is likely the case, is that we haven't evolved. Our spines have not evolved to the upright posture. And as a right, the vast majority of people have back pain. And this can be verified because if we look back 200 years when we measure the prevalence of back pain, it really hasn't changed to today. And no matter where you go around the world, you go to the third world, the first world, Japan, Asia, Africa, it doesn't really matter. The prevalence of back pain is the same. So why is that the case? So there must be something that's intrinsic about human beings, about back pain. And we think it's this whole thing about evolution. Because when you stand up, the mechanics of the back are very much different than when you're on all fours. The weight is distributed differently. And so when you stand up, these forces in the lower back are likely accumulative over time and cause straining of the back. And perhaps in 1,000,000 years, when the evolutionary process is complete, then back pain will go away. But in the meantime, it becomes a huge problem for humans. There's a variety of different treatments for back pain. When there is no magic bullet and nobody has the single solution, then everybody has their own way of treating back pain. So there are very, very many different treatments. But if you're asking me what are the most effective treatments, there are very few. So the American College of Physicians just published their guidelines on the treatment of back pain this month, actually. And it's an update from their 2007 guideline. And basically what they said is that in terms of medication should not be the first line of treatment for back pain, because for the most part, medications don't work. So there's lots of different medications out there, but very few of them are shown to be effective. Some show some small improvements and for a very short period of time, but for the most part, medications don't help patients who have back pain. And the same goes for sciatica and spinal stenosis, that medications don't tend to work for these particular problems. The treatments that seem to be most effective for back pain, and that's exercise and self-management. So when we look at the data and the research for chronic recurrent back pain, which is the most common, people who have ongoing problems, exercise is probably the most important thing that people can do, as well as maintaining activity. So we know that limiting activity and sitting and lying down and waiting for your back pain to get better is the wrong approach. Exercise is actually the only thing we know that helps to prevent recurrence of back pain. So really it is around exercise, and the question is what type of exercise. And this is where there's lots of controversy in the literature and there's controversy in guidelines, because we really don't know what is the best exercise. And it may be because the exercises need to be tailored to the individual. Here at Mount Sinai, we've developed our own programs here, and they're called the boot camp programs for a variety of different conditions, like spinal stenosis being our most common one we see. I'm the director of the spinal stenosis program here, so we have a very specific program that's very exercise based and is very specific to the condition. And I think this is where I think we might be able to get better results in the future, is to make the exercises very specific to the biomechanical nature of the back problem and very specific to the individual and how that back pain affects them. Does it affect you when you bend forward? Does it affect you when you bend backwards? Does it affect you when you sit, when you lie? And those particular clues will help me, the clinician, to develop a program that's specific for the individual. So the specificity and the tailored nature of programs, I think, might help us to become more successful. But exercise needs to be at the core. The second thing is self-management. Because these problems are chronic recurrent, so once you have a back problem, you have a high risk of getting this back problem over and over again. And even if you have a back pain problem today, your first episode, the likelihood that it's still there in a year is very high, between 20 and 30%. So the way we treated it in the past was very episodic. You have a patient has a back problem, you treat that back problem for today, and you don't worry about the potential of that problem coming back. So what you need to do is to develop self-management strategies so patients know how to manage their condition, not for that one episode, but to do things to prevent that episode from coming back. And one of the core things is exercise, but also how to sit, how to stand, how to walk, how to sleep. All the things they do every day, they need to be able to do in such a way to minimize the load to their back and the strain to the back. In our programs, what we do is that we translate exercise, not only that you do exercise twice a day or once a day and then you're done with it, you actually translate the exercises into the activities you do every day. Like, how do you engage your core when you're standing brushing your teeth? This morning when I was shaving, I engaged my core in order for me to take the load off my back. And if we can remove or eliminate the small accumulative stresses over time, shaving, brushing your teeth, sitting, different things we do every day, and reduce the load to the back and just take that load elsewhere, like to the core, then we may be able to reduce the recurrent nature of the back problem and reduce the episodes that patients will have in the future. And the most important for me in my clinic is reduce the likelihood of disability because of back pain. Back pain is the #1 cause of disability in the world. And this is actually increasing because of the aging population. The severity of back pain tends to increase over time, and the risk of disability increases as well. And that has to do with the fact that the spine is more vulnerable, it's arthritic generally, and it is more likely to be out of shape. And so it increases the risk. For example, lumbar spinal stenosis is a leading cause of pain, disability, and loss of independence in people over the age of 65. It's an arthritic condition that affects the spine that we all get as a result of aging, but some people get it more than others. And this condition is epidemic now in countries like Japan, which has an older population, in Denmark. And in the next 15 years, approximately 3 million Canadians will have this condition and will impact their ability to walk, to function, and to maintain their activities of daily living. So it's a huge problem. And our program here, the boot camp program for spinal stenosis, we just completed 2 clinical trials that show that it does have a very, very positive effect. But the core is exercise, self-management, self-monitoring, because again, these are chronic conditions, they have no cure, and the patient has to learn how to self-manage for the rest of their lives. And we've shown in our clinical trials not only short-term benefits, but the benefits are sustainable at 12 months, and the patients are taking control. It's the patients that are knowing what they do and how many times they have to exercise, what exercise they need to do, how to sit, how to stand, how to walk, how to drive. And these things have been showing in our clinical trials to demonstrating a significant improvement in their ability to walk, to stand, and to function. The literature seems to suggest that if patients are mildly or moderately overweight, then there's not a big connection to back pain. It's when the patients are very obese, then there is a stronger connection, because patients who are very thin also have back pain. And so being thin doesn't protect you from not having back pain. You might have an increase in perhaps the severity of back pain as you get older, particularly if you're obese. But I don't think that losing weight alone will get rid of back pain. So I think it is a factor, particularly in those who are obese, but it's not a very large factor in preventing back pain. So there is a higher risk of people who smoke to having back pain. Number one, in terms of the prevalence, and number two, also the likelihood of you becoming disabled because of back pain. We don't really understand the underlying reasons for that, but it's likely because of healing. So smoking tends to slow down the healing process, and perhaps the smoking impacts the ability for the tissues to heal properly, the lack of oxygen. We're not quite sure exactly, but smoking is a risk factor for back pain, both in terms of getting back pain, but also getting better faster. If you're a smoker, you'll tend to do not as good. Back pain is part of the human condition. And so to try to prevent back pain is probably very futile. Again, going back to this spine that hasn't totally evolved. So I think we should be focusing less about preventing back pain and more about, when the pain comes, is how to manage it correctly to minimize reoccurrences that are significantly impacting people's quality of life. For example, when we do our clinical trials, in some patients the pain doesn't go away. Especially in spinal stenosis, we don't expect the pain to go away because it's a chronic condition. Patients have arthritis in the spine, which is wear and tear. We don't expect the wear and tear to go away, so we expected the pain to continue. But what we were able to do is to maximize their function, reduce their risk of disability, improve their functional status, improve their walking. So patients are able to manage better their pain and to minimize their risk of them becoming disabled. So the focus has to be less, I believe, around preventing back pain, because we've failed in the last 200, 300 years to prevent back pain. And I don't see us preventing back pain in the future. I do see us able to manage back pain, making back pain less of a disabling problem, teaching patients how to manage, even with pain, maintaining their function, their quality of life. And I think the pain, we can find ways to reduce the pain, but to eliminate back pain, I think it would be an impossible task. What are the common mistakes? One of the common mistakes is thinking that by giving a patient a sheet of exercises that when they have back pain and sending them home will work. And after 35 years, I still get doctors sending me patients asking me to give them a sheet of exercises and send them away on their home. It doesn't work that way, so that's one mistake. Patients need guidance, need supervision, they need to know how to do the exercises correctly, and they need the motivation and the coaching. So I think one of our clinical trials shows that when you coach patients and when you show them how to do self-management, that you get better results. So I think providing patients with the knowledge, the skill, and the confidence to self-manage is the key thing, but you need to coach them and you need to supervise them over time, just like the diabetic patients. I use the analogy of back pain like diabetes. Diabetes, there's no cure. There's no cure for back pain. So in diabetes, you have the patient come in, you explain to them about their weight, they have to lose weight, they have to watch which foods they eat, and they have to monitor how their blood sugars are doing. And then they take control of their own condition. Back pain's the same thing. For patients who have difficulty walking and functioning, you give them a Fitbit, you give them something to monitor their physical activity. You tell them things they need to do, how to sit, how to stand, how to walk. You tell them what exercises they need to do specifically for them. So it has to be very tailored and a very chronic disease model. So the fact that patients are getting one sheet of paper to send them on home doesn't work. The second thing is medication. Medication, number one, doesn't show to be effective. Number two, it's a passive way of treating back pain. Patients need to take involvement of their pain. There has to be work involved on the patient's perspective. Exercise, self-management strategies, how to sit, how to stand, they have to take more control, and medication is not the answer, as just shown again recently in the guidelines that were just published by the American College of Physicians. Medication is not the way to go to treat back pain. And avoiding passive modalities, and medication is just one. Passive modalities like ultrasound, where patients are getting things done to them as opposed to them doing things for themselves. So, machines or traction machines or even massage and chiropractic treatment, if that's all they're getting, manipulation or massage, then that's the wrong approach. So patients need to have an active participation, combining those things like manipulation, which does work. We know it does help back pain, both in the acute and the chronic phases, but it should not be the only thing patients should be getting. Should be combining, again, as I mentioned, the exercises and self-management strategies, and give the patients the knowledge, the skill, and the confidence to manage the condition moving forward as they get older, but also for the rest of their lives, because once you have back pain, you're at a high risk of getting it over and over again. So those are the things. The other mistakes is to treat back pain as a single episode. As I mentioned to you before, that once you get a back pain, you have a higher risk. If you just treat it as an episode and say, let's get rid of the pain for today, and then forget about the future, then that's also a mistake. Trying reducing the recurrent episode of back pain and reducing its severity goes back to those principles that I mentioned earlier. So not taking it as an episode, but preparing for the next attack, or trying to minimize the next attack through some of the strategies that patients need to learn how to do. It is the first approach, but the guidelines now suggest that it should not be the first approach because it's not been shown to be effective, and there are side effects associated with it. So if you look at aminocentephine or Tylenol, you look for anti-inflammatories, you look at opioids, you look at muscle relaxants, they have small effects and only short-term effects, and they're associated with side effects. And so when you compare them to other non-pharmacological treatments like manipulation, exercise, that they're either not as good or they're just as good. And so why go that route when it's, again, a passive route where patients are taking medication and then expecting the pain to go away, and where the other alternative is where they participate in their own healing and they participate in them getting better. And so the guidelines, and these are medical guidelines that are for physicians, are telling them now they should not think as medication as the first line, but looking at non-pharmaceutical as being the first line for patients, because the evidence now shifting away from medication into non-pharmacological options. Yeah, one myth is that we know the cause of back pain. That's one myth. And again, in 90% of cases, we do not know the cause. We don't know, we can't identify exactly where the pain is coming from. So oftentimes we think we know where the back pain is coming from, but in fact we do not. So that's one myth. The other myth is that that back pain is an episode that once you get the episode, it gets better, and then that's the end of it. And research doesn't support that. Back pain is not an episode. It's a chronic recurrent condition. So we need to look at back pain differently, not as an episode. You get back pain for a few days and then goes away. We have to look at back pain as once you get back pain, you have a recurrent, you have a high risk of getting it again. So the myth about, the back pain goes away within 4 to 6 weeks and then you're all cured and you're done with is not true at all. It's a chronic recurrent problem. So that's probably the second myth. And then the whole area around disability of back pain. Disability can be prevented, and it's a myth that disability cannot. There's always going to be a certain percentage of people who are going to be disabled. But if we look at various countries around the world, some people have higher disability rates in back pain than others. So there are many factors that impact someone being disabled from back pain. And I believe that back pain disability prevention is where we have the highest likelihood of helping patients, not getting rid of their pain, but minimizing the risk of becoming disabled. And I think that's another myth around that patients can be, there are solutions and there are strategies to minimize disability. And I think that's where we need to go, both in our research, but also in how we treat patients. And to say, well, every patient that comes into my clinic, the first thing I teach my students is what we're going to do what are we going to do for this patient to minimize this patient becoming disabled because of their back problem. Because the fact they're here to see us because of back pain, that means they're at high risk of becoming disabled because of back pain in the future, given it's the #1 cause of disability. #1, if they're coming in with back pain, they're more likely to have it in the future. And if they're getting older, they're likely to get their back pain become worse, and they're more likely to become disabled as they age. So we need to be looking on preventative measures on disability, and not necessarily eliminating pain for the rest of their lives, which is, I believe, a myth and a falsehood that we can do that. I don't believe we can. Maintaining activity is the key. So when you have a back episode, whether it be a sciatic pain or stenosis problem or acute episode of low back pain, the body will start to heal once you have that episode. And in order for it to heal properly, it needs movement. So movement, we know, for example, nowadays when you have surgery, whether it be knee or hip or back, they get you to move within the hour, whereas 30 years ago you would be in bed lying down. So movement is key. Movement is key for a lot of reasons, but in the area of back pain, the joints in their back only get nutrition. The joints themselves, the cartilages around the joints get nutrition through movement. So without movement, then you don't get the proper nutrition required for healing. So movement is the key. So that's one thing they need to do. They need to exercise every day, at least 30 minutes of aerobic exercise. There are a number of studies showing that half an hour exercise a day aerobically can reduce your risk of heart attacks, reduce your risk of back pain episodes, reduce your risk of heart attacks, strokes, Alzheimer's, diabetes, and obesity, just half an hour a day. So patients can do themselves a good, not just for back pain and neck pain, but also for their overall health of exercising at least a half an hour a day. And the other thing has to do with the whole changing of behaviors. And this is a key thing in health, is changing behaviors and attitudes and beliefs around their pain. For example, the patients who have spinal stenosis who come to see me, the first thing I tell them that if they're here for me to eliminate their pain, they're in the wrong place, because I cannot get rid of all their pain because it's an arthritic condition. So we need to change the focus and around pain and sort of focus it on function. So then we do say to them, but we are going to help you in most cases improve your ability to walk, improve your ability to function, improve your ability to vacation, improve your ability to do things you like to do. So there is a changing in attitudes and a changing of a belief system where pain is the focus, where in back pain, when you focus on pain, you become trapped and your pain doesn't go away. When you start to think away from pain and focus on function, your pain gets better, your quality of life improves. So what patients can do for themselves is focus not on the pain, because in most cases when you have pain because of back pain and you're going to do activity, it's not going to harm you. You'll feel pain, but it's not likely going to harm you. It's likely going to do better for you in the long run. So maintaining activity, maintaining at least 30 minutes of aerobic, doing specific exercises. And then the other thing, which is the way we do it here in our clinic, is we translate the exercises you do. So in our program, we don't just do exercises for that once a day or twice a day and then you're done with it. You translate those exercises into activities of daily living, as I mentioned, the way you shave, the way you brush your teeth, the way you blow dry your hair, the way you sit, the way you sleep, the way you lift the groceries out of the car. You have to engage the core and activate those muscles that you're exercising during the daytime to translate them. And that's where our programs are quite unique, because that hasn't caught on yet. But with my workshops and with my education to my trainees, and we do these kind of workshops, is that we want to get patients to understand that those muscles need to work not just when you're exercising, but engage those exercises and those core muscles when you're doing the activities of daily living. And we think that will do what? Will keep the patients functional, will keep them active, will keep their quality of life high, because they're doing the things they need to do and want to do.